we're going to set a stage for what FHIR is. It's also a really good undertone for being sort of a footnote for Andrew's presentation. Probably most of you wonder what FHIR is. We're going to talk about the core FHIR principles behind that. What does the international landscape look like? What's FHIR been, how's FHIR been adopted in Canada? And then we're going to talk about the future. So let's get started with setting the stage. Before I get into the details, do you mind a show of hands of how many of you have heard of FHIR? Very nice. Very nice. Now, how many of you have worked with FHIR? So a little bit fewer, but OK, that's still good. So since you have heard of FHIR, I'm not going to bore you with the small details, but I think it's very important to look at this diagram for a moment and recognize the very quick journey that FHIR has gone through. It started really in 2011, and that was a realization of HL7 International that their products at the time, which was HL7 V2, were really aging. They were over 20 years old. And the V3 was not really getting the adoption that it was expected to get. CDA was kind of coming along, but it didn't really tell a good story for the future. So what HL7 International decided in 2011 was to kick off the Fresh Look initiative. And what they asked their community of members was to go away and try to think what would be the standard of the 21st century. So they came back and they came up with some very good ideas. And the next 2 years were spent in trying to sort of kick the tire of these ideas, to do proof of concepts and so on. It turned out to be very successful, and then the vendor community and quite a few government agencies started getting involved after that. And what we're witnessing right now is we're right at that threshold where HL7 International is expected that in the next year, probably September of 2018, about 10% of the FHIR resources are going to go normative. What that means is that they're going to be backwards compatible from that point on. Right now, there's a lot of breaking change in it, and it's on purpose, because they want to go fast, but they want to work with the community. So what makes FHIR so great? Quite frankly, for those that have been involved from the beginning, and we have, FHIR turned out to be, frankly, a scavenging activity throughout whatever works in the world that fixes problems. They borrowed from the healthcare industry's standard agencies that have had success, but they also went out of that, outside of the realm, and looked what works in other industries. So this is how they came up with the concept of encapsulated structures. DICOM has done that 15 years prior. They have come up with the idea that if I focus on the 80% and relegate the 20%, which is complicated, to the realm of extensions, then I can let people go very fast with the 80, still allowing for the opportunity to enhance. They also embraced from the get-go the concept of terminologies, which was a little bit lacking in the old days. And now they're getting a forefront because semantic interoperability is going to be extremely crucial in the near future. And then all these components that have been refined in the so-called FHIR resources were bundled together in such a way that they allow the communities to implement very focused and targeted solutions. So, international landscape. We just had the presentation from Michael this morning, and we have seen how countries fare when it comes to delivery of healthcare. Well, it's no surprise that it is exactly those countries that also appear as being at the forefront of the new FHIR movement. I want to make something very clear. FHIR is not V3. It's completely different. It's a different set of people and a different attitude that are working towards this. Vendors are very much present. Software developers are doing it. So what you're really witnessing is this tremendous energy in the room. For everybody that hasn't been, I highly recommend to go to the new HL7 international meetings, especially the Connectathon. It's fierce, like seriously, 200 plus people coming together trying to fix real problems, and they are doing it. So the very premise of FHIR was that this standard is supposed to be able to render its own self. In other words, no more paperwork, everything is done online, and everything needs to connect. So changes to the standard are done in such a way that if it doesn't work in a computer environment, it's not part of the standard. So everything has to flow. And it employs the basic tenets of the web development. So it's RESTful interfaces. Of course, Andrew mentioned you can also do messages if that's basically your architecture. You can do service-oriented architecture or services. That's quite all right. Okay, so what have we seen in Canada? What we've seen in Canada was a little bit of a slow start. It's probably fair to say that coming out from a decade of development using V3, there was a definite fatigue in the country. And people were very hesitant into jumping something new that they didn't understand. In that regard, we are lagging behind the international community by probably about 3 years. But the good news is that some of our Canadian colleagues are actually sitting at the table where FHIR is being developed. Their input is absolutely invaluable, and to bring out James Agnew's FHIR server, developed at the UHN in Toronto, it's the most downloaded and used FHIR server in the world, even today. It's a freeware. And this is, by the way, very interesting in the FHIR community. Pretty much everything is shared for free. It's an open community that is driving towards sustainability. So we have a very good international participation. We're also starting to see very good community engagement. And as Michael was also pointing out, our role as a catalyst, what we really can do, being such a small organization, is recognize trends, bring it to the forefront, present it to you guys, and try to work with the community to get off the ground that which is really worth doing. There's also very good grassroots activities organized by some of our colleagues. FHIR North is a perfect example where Mohawk College stepped forward and offered their their grounds to come innovate, to try out these FHIR messages, and there's an annual Connectathon going on there every single April. I think we should scale these activities throughout the country so that other provinces also get a chance to partake in it. Those are the technical events. Vendors have already been very interested in FHIR, and we know of a lot of projects that are going on in the country. Unfortunately, it feels a little bit like the underground project. People are not really talking about them, and we need to change that. So I will turn it over to my colleague Yaron here, because some of the community work that we initiated about a year ago, he's one of the co-chairs of that community engagement.
So a little bit of context around why there's a FHIR Implementation Working Group. So Ontario, like many of the other jurisdictions and products out there, my team supports or develops the HL7 version 2, version 3, IHE's XDS profile and CDA specifications. So we are what would be called a brownfield. We have lots of our electronic health record assets today support interfaces that are actually flowing information to and from places using the classics. So it's not that easy to just turn on a dime and use something else unless there's a good case for it. So in Ontario, we're fortunate that we do have a couple of evangelists, and as Attila mentioned, we also have some experts, but having an evangelist in the ministry really helped to turn the corner around moving towards FHIR. So this takes us to about a year prior to today, and we have already in place digital health drug repository, DHDR, and that's purported to be the largest FHIR-based repository in the world. We also have an immunization repository that's FHIR-based, and then we have a couple of other jurisdictional projects coming out of Ontario MD, coming out of Ontario Network. They're also using FHIR for their specifications to get data in and out of electronic medical records. So the province definitely is moving towards adopting FHIR for new projects, but what do we do about the current projects, and how do we move forward? The one great thing about FHIR is that it really is really easy to learn. The difficult thing about it is it's so easy to learn that people might go ahead and do their own thing. So we really wanted to make sure that we were doing things together with our colleagues. So, okay, let's do that again. Okay, there we go. Okay. So there was this is on the right-hand side. You'll see that the InfoCentral screen. It looks very familiar to those that have been on InfoCentral. So of course there was questions starting to flow around FHIR, and so I just said, let's have a meeting. And we had 20 people show up on a teleconference, and the working group was launched from there. And I'm pleased to say that it's November is our 1-year anniversary. We have 130 members from across Canada, both from private sector, from public sector, and quite a good amount of traction. So that's a very good success to date, because there is so much interest about FHIR, but at the same time, people are all grappling with the same things. So, so we wanted to make sure that the work that we were doing. Cool. So Gavin Tong from Jevity and I volunteered to be the co-chairs, and there were two things that we made sure that we didn't want. One is we didn't want to be heavy on governance, and the second thing we wanted to make sure is that we weren't taking the approach of, if you build it, then they will come. We wanted to make sure the work that we were doing was stuff that was practical and stuff that people were interested in doing work on. Now, so we put a call out to our participants, and we were able to strike 5 work streams. So you see over here, those what's really nice is if you look at the logos on the side of each of the bubbles, those are the co-chairs organizations, and you'll see again, it's a nice, broad, diverse group of public and private. So we tackled things like, what's the value proposition for FHIR, which is a little bit difficult to do when it's something new, but we put our best foot forward. Tooling, that's something to look at. How do you prepare and publish FHIR specifications for other people to be able to use and download and build off of? And so that's, we're going to continue on that to when Attila joins back again. Client and provider registry. So Ontario has already built, we're in progress of making our FHIR FHIR APIs for our client and provider registries available in the next coming quarters. And so we already have our specs, but we want to make sure that we're not building a made in Ontario approach. So we struck a group where we were asking whether other jurisdictions that have registries could use the same specification. And then solution architecture is very important because, as was mentioned in the previous presentation and this one, a lot of current application architecture today is based on service-oriented architecture, or SOA, and FHIR is based on representational state transfer, which is known as REST, the RESTful paradigm. So migrating from SOA, from service-oriented to RESTful-oriented is not hugely different, but there are things that need to be thought of, and this working group is still tackling those types of issues. A new working group that's launching, and we're hoping that folks in the crowd will be wanting to join this, is Smart on FHIR and Clinical Decision Support Hooks, CDS hooks, which is how do you bolt on applications that can quickly and easily bolt onto bigger systems and exchange information to add on to the value and capabilities of existing systems. To give you a sense of the value of this working group approach, as well as what makes FHIR different, I want to focus a little bit on the e-referral bubble on the top right. So you'll see the e-referral use case that we're tackling is something that's very relevant in Ontario, but I think it's relevant across Canada, which is you can either have e-referrals being generated by any type of practitioner or even by a consumer, by themselves. There are certain things that consumers are going to be, they're going to make their own self-referral. They might be using a point-of-service system, or they might be going straight into an e-referral platform. But they'll be limited into the types of services that they can support, to the type of services they can request to the platform that they're on. That platform has to be able to connect to other platforms that might be supporting other services, so that expands my ability to search what type of services I can get, which might be better for me, and to complete the full e-referral. So CareDove and Orion are two of the e-referral platforms, and they stepped up to be the co-chairs. And I'd be remiss to point out that Chris Lewis from CR Systems is here as well, and he's the co-chair on several of the work streams. So rather than describing myself, I wanted to start off by a video. It's not as good of a video as what we saw yesterday. It's self-produced by Tim Berezny from CareDove, but hopefully it'll illustrate to you a little bit why FHIR is a little bit different.
Here is a simulated electronic medical record system or care coordination system holding some patient profile data. What I'm going to do is look within its internal service directory and select a service to refer to. In this case, I'm going to choose the Orlando Meals on Wheels program provided by API Alliance Health. And here is information, the ID and endpoint that is required to route the referral to the correct location. I can preview the JSON that's going to be sent. Here it is, it's a bundle. You can see all kinds of information that gets sent through. And I'm going to send it through. Refer. So now if I look at the referrals list, there it is, the referral's been sent to Orlando Meals on Wheels. There is no appointment yet. Status is pending. So let's go look at the receiving agency and see what has shown up there. So here is the referral. Peter Nicholson was the one that was sent for Orlando Meals on Wheels program. I can click into it and view the referral that was sent. Here is all the data that was included in that referral package. Now, what I want to do with this referral is to give it an appointment time. So let's book it. So let's say 11 a.m. is going to work. So at this point, the receiver might be on the phone with the patient, or maybe they're assigning a time slot, but it has now been booked. Turn to the sender's EMR. When we go and look at it, you can see the appointment information has been sent, has been updated back in the sending system. Status is booked. And it's a neat little trick here. You can do FHIR actions to get a number of resources that are available with this referral. So here's the process we did. Within a requesting system, we looked up a service in a local address book, then we used that information to directly send it using FHIR to the receiving system, where an update was made to add an appointment time, and that appointment time was sent back to the sending system where it was updated in its own system.
Now, wasn't that exciting? So I'm only being slightly facetious. How many people have ever seen a video like that for any other standard? Oh, okay. I think statistically we're doing well. But so you might see something like this if you went to an IT Connect-a-thon, but you wouldn't see something like this graphical visual. You'd see back-end systems, people sweating, trying to get something to work. The beautiful thing, that what's different about FHIR is that it's based on the internet, so people can pick it up, learn it quickly, visualize it, and get going really quickly. Tim, it doesn't have a background in FHIR, and he put this together using an EMR facade that he built on his own, and then talking to his own product, CareDove, was able to demonstrate this in a couple of weeks. This is something that we can use to get a lot of momentum, get a lot of buy-in, and hopefully get a lot of people to say, you know what, it's worth it for me to put aside my own way of doing things and working collaboratively to solve the same problem across Canada. And that's really the call to action is, Ontario, we're like I said, we're committed to putting FHIR into all of our digital health assets as the opportunity presents itself. But we want to make sure we're not making made in Ontario solutions, and we want to make sure what we're building is conformant to FHIR. So what we really need is we need somewhere where we can both share, collaborate, and learn from other people. And so the Pan-Canadian FHIR Implementation Working Group is where we share that knowledge, but we also need a place where we can share in terms of a space. And with that, I'll pass it back to Attila.
Thank you so much. Yes, it is now. So I think this is a great success story, especially since the FHIR Working Group, Implementation Working Group, has only been around for 9-10 months. In the beginning, we were trying to get into a rhythm where you don't really step on each other's feet and everybody can go and do whatever area of interest there is with a very finite goal in mind. So we were not in favor of having committees and do voting on it. Rather, people sign up, they're interested in something, they go away, they do something, they come back, they present it, and then that can get a foot, right? One of the working streams that Yaron mentioned was the tooling working stream. I personally take very much to heart lessons learned from the V3 experience that we had in this country, and all around the globe, actually. One of the problems that we learned there was that because of the complexity, tooling was coming too late, and people went out and did whatever the heck they thought that they could do and had to do, because frankly, there was nothing else to help them. Because of that, you saw a lot of divergence, and you had a lot of very hard work. So the very first thing that we started doing with the new working group was to look what are the FHIR components that need to be handled by the community at large. And the diagram is the same that you saw before. I added an envelope to it, which is called the implementation guide. Andrew was showing one for the prescribe it solution. So when you dissect this solution and you start looking at its components, you recognize the huge opportunity for divergence here. So yes, FHIR can go very fast and almost everybody can learn it. The problem is that if everybody goes away, learns it, and start using their own resources in an ad hoc manner, you end up with 1,000 patient resources, all configured differently. So when you're trying to exchange, you're still breaking interoperability. So you are going to have fast solutions, but not interoperable ones. So this has been recognized in the tooling work stream, and one of the first things that came out of it was an aggressive hunt for an international solution that could help Canadians with this. And the good news is that that solution is born right out of the thinking minds at HL7 International that are doing the standard. This product is the Canadian FHIR registry that we launched last month. It's built on a platform built by a company in the Netherlands, one of the promoters and the pioneers of FHIR development and integration. And they have a brilliant business proposition there. They give you for free all the tools needed for authoring, and also the platform to host the results of that authoring. So the solution that you're creating can be shared immediately with everybody for free. And the only sustainability model built into their solution is that in case you want collaborative development, as in you want a team of, I don't know, 20, 40 people come together to work towards a prescribed solution, for example, then you have to pay for the project to be hosted there. So Infoway has picked up the tab, and we basically pay for the Canadian FHIR registry and open up all those projects for the entire Canadian community to come forward and work out of it. So you can get a free editor, which is state-of-the-art, and then you can automatically link it with GitHub. For those that are techies know how good that is. And the registry picks up automatically, synchronizes your project information in that space. So you can go from nothing, Stone Age, to Space Age in literally one registration. That's amazing, I think. So this is one of the things that we have launched last month, and I'm here to tell you that this thing exists. You have no more excuses if you want to go fast and you want to truly participate in the community. We have choices for you. Another component that was in that previous diagram of how things come together was the terminology. Andrew already alluded to this. We have been working on this 2-3 years ago. When we saw FHIR coming, we kind of anticipated that the need will be there very soon for the terminology to be electronically available. And I'm glad to say that it is now needed, and we are ready. So all the value sets that you usually use, the SNOMAD, the LOINC, the HL7 codes that you need are available in the terminology gateway. You can bring your own solution. We can upload it for you. So you can truly be independent while part of the collective. And there's huge value in having your your solutions listed there, because then people will pick it up and they will probably innovate on top of what you already invented, not have to go back and do basically just run-of-the-mill and infrastructure. So there's a lot more additional help. Obviously, I cannot cover everything in 20 minutes here. Our call to action is please come back, educate yourself, get in touch with us. We have a lot more to offer. Some of the solutions are listed on this slide, but obviously, this is just the tip of the iceberg. So with that, I think the final takeaway I just mentioned. So this is it. Thank you.
Thank you very much, Attila and Yaron.